Okay, we're going to go ahead and get started. Welcome back, everybody, to the Innovative Discovery series of lectures. Make sure you sign in. Also, please start with speakers so you can better prepare for the next session. Online participants, please keep your mics muted unless asking a question, and keep the video turned off. Our next talk is going to be Rich Life, Reducing Hypertension Disparities by Lisa Cooper from Johns Hopkins. That'll be on June 17th. Public Tools for Studying the Genetic Basis of Complex Disease by Julie Bartol, a colleague from the Moores, who's one of the co-PIs of the CTR grant. Full schedule is available on the ACCEL website. And of course, all previous presentations are archived on the website. You can see them at any time. It was really a great pleasure to introduce today Dr. Kurt Garratt. I think almost everyone in the room knows him. He's from California originally, although we'll forgive him for that. He went to college and medical school there and then trained at Duke and Mayo Clinic. Joined the faculty at Mayo Clinic, where he was for many years, and then was in New York for ACCEL for approximately 10 years before joining us about 10 months ago. He's had an enormous impact here at Christiana, and he's going to speak today on optimizing value through appropriate use of invasive cardiovascular services. Great.
Thanks a lot, Bill, and thanks everybody for coming out. Thanks for giving me this opportunity to speak to you today. I'll start by disclosing that I'm not a healthcare economist. I'm not trained in healthcare regulations and so forth. But my particular career trajectory has kept me bumped up against issues having to do with quality management, process improvement, and that naturally then spills over into the regulatory environment. And so I've found myself in an interesting position, spending more and more of my daily life engaged in processes that are aimed at assuring that we deliver an optimal healthcare product. Meanwhile, in my spare time, I'm an interventional cardiologist, and so you have to keep that in mind as I make my remarks. There's probably advance the slides. Hopefully I don't have to do this to advance every slide. There we go. All right, so here's my formal disclosures with regard to anything you might be considered a conflict of interest. I don't think anything will have an impact on this talk, but the real disclosure is the following: that if you ask me what I do for a living, I'm going to tell you I'm an interventional cardiologist and incredibly proud of the fact that I've had an opportunity in my life to have a positive impact on people. I believe in the work that we do in the cath lab. I believe it has very high value. I believe it's a noble profession. And I'm really happy about the fact that I've had an opportunity to impact lives, even save lives, by virtue of the procedures that I've learned to perform. And that's probably the most important thing to keep in mind when you hear the comments that I'm going to make. Here's what I'm going to talk about. In some ways, this is an updated or a variant form of the talk that Dr. Weintraub invited me to deliver about 2 years ago when I first came into contact with Christiana Health System. I'm going to talk about the new epidemiology. I'm then going to provide some brief financial and performance reports having to do with cath practice. I'm going to touch on the topic of constraints and how we might embrace constraint going forward, and then I'll summarize a model of what I think will lead us to the right balancing point for invasive cardiovascular value. So first, we'll talk about the new epidemiology, and section 1 leads us to sad fact number 1. And here is sad fact number 1 for you. The people just don't love me the way they used to. You know, I feel bad for poor Dr. Troiano here, who's going to now spend the next year with us learning how to do interventional cardiology. And he'll come out an invasive guy. And you know, 15 years ago, 10 years ago, you come out of training and you are instantly a rock star. Everybody loves you. The hospital loves you. You provide a lot of value to the hospital in a financial sense. Patients love you. Everybody loves you. People don't love you the way that they used to. And the reason for that is that we've had something of a perfect storm of events that have led us to a changed reality. This is a slide I actually used 2 years ago when I talked about the perfect storm of interventional cardiology change, consisting of a reduction in demand for services, a reduction in reimbursement for the services that we render, and falling confidence in the things that we do. The public perception of interventional cardiology has changed an awful lot in the last 10 or 15 years. Well, why have those things happened? Well, I think they've happened for several important reasons. The first is that we've gained increased clarity about the benefit and the limitations of the benefit that we can provide through CAPDAC. That has led to an improved appreciation of the appropriateness of some of the things we do and the limit of the appropriateness of things that we do. And in part, we have, in my opinion, been victims of media coloring of what we do. And I think as a collective community, the interventional cardiologists have not been as effective in addressing public concerns as they might have. I'm not going to touch on that further, but those are just my thoughts, and I've structured my further slides around these thoughts. There we go. First, let's talk about how the epidemiology has changed in a manner that makes interventional cardiology seem different in 2016 than it did, say, in 1996. This is a graphic of what's happened over the past 15 years or so with regard to the incidence rate of heart attacks. That's probably the most dramatic environment or episode that calls interventional cardiologists to the bedside. And what has happened? Well, what you see here is that myocardial infarction, heart attacks at the very top there, 20% reduction in roughly a decade and a half. 20% reduction. Now, most of you are clinicians, but for those of you who are not, I'll just disclose that heart attacks are normally thought of as coming in two flavors. The non-ST elevation myocardial infarction, which can be a very, very serious matter, typically is not linked with death rates that are quite as high as the ST elevation myocardial infarction. That's sort of the big one. And what we see in this graph is that the somewhat less severe heart attack forms have not really fallen off very much. But there has been a huge reduction in the big one. Now, that's an interesting thing, and you would expect that that would spill over into improved outcomes in a lot of spheres. For example, mortality, and in fact, we do see an important trajectory change with regard to CV mortality. It didn't start 15 or 20 years ago. It started way back around 1970. And there are a lot of things that have contributed to that. This slide contains just a few of the highlights. How do interventional services factor into this picture? Well, way back in the late 1950s, we discovered how to do selective coronary angiography safely. I suppose most of you know that this happened in Mason Sones in Cleveland, and it happened quite by accident when, in the course of performing a non-selective coronary angiogram, which was the standard means of trying to get a look at the heart arteries, an injection was made in the aortic root, and catheter slipped into the right coronary artery. And you see, it looks up on the fluoroscope and sees this beautifully delineated right coronary artery. That made him smile. An instant later, he was sweating bullets because, of course, the patient was fibrillating, and he had to run up and resuscitate the patient. The patient survived. But he realized, wait a minute, we performed a very uncontrolled injection in an unplanned manner, and we're able to get through it. Maybe if we step back and think about this, we can figure out how to do this on a routine basis in a safe manner. And that was done, and of course that opened the door for everything that's happened subsequently in the field of interventional cardiology. Angioplasty was developed not in 1979, as this slide indicates. That's the year it was first performed in the U.S. Andreas Grunzig actually performed the first PCI in 1977 in Zurich, Switzerland. Next summer will be the 40th anniversary of that event. That, as you all know, led to an explosive exploration of how angioplasty might be used to improve patient care. Initially, this was thought of as a therapy for patients with stable angina. The prevailing belief in the 1970s and even 1980s was that patients who were having heart attacks and the like were far too unstable to go to the catheter laboratory. That would be unsafe. And it took a few pioneering people like Bill O'Neill and his associate Cindy Grimes from Michigan and others from the central part of the country to craft trials that proved that, in fact, not only could we perform angioplasty in the setting of a heart attack safely, but ultimately, by the early 1990s, we were able to prove that it provided better outcomes than alternative cares like the administration of blockbuster drugs. And then finally, we've had the ascendancy of coronary stent products, which are permanent implant devices, which are aimed not just at stretching open the blood vessel, but holding it open. The contemporary devices, I can tell you, are a miracle of engineering. We tend to be sort of dismissive about these simple little scaffolds that we insert there, but I'm telling you, if you just spend a half an hour even Googling this and looking at what has happened in the past 15 years in this area, you will be dazzled. The products are amazing. The things that they do are amazing. It's really been an incredible journey. And look at how those things have trended along with that fall in mortality. Fabulous. Love to take all the credit. But, of course, can't take all the credit. What do we think has actually caused this big reduction, 75% reduction in cardiovascular mortality over, say, 60 or 70 years? Well, I'm not sure anybody knows for sure, but this was a good stab at it. The paper is a little old now. But in this study, various elements that are employed in care of patients with cardiovascular disease were evaluated for their impact on mortality, and these are the conclusions drawn. You can see in this exploded pie chart that in this, I don't think I have a pointer here, this pale blue wedge at the top represents all therapies for acute coronary syndromes. Those include heart attack patients. In this analysis, this was looking not at the big one, but the non-ST elevation infarcts in patients who have unstable chest pain patterns and come into the hospital. Well, that seems to have contributed a bit. In the red wedge there at about 1 o'clock or 2 o'clock, those are the revascularization therapies, surgery, and importantly angioplasty for those patients who have heart attacks. And then there are similar revascularization therapies for patients who just have refractory angina that can't be managed well with medications. You can see if you bundle all those together, and that involves surgery and medicine as well as angioplasty, but let's just imagine for a moment that represents predominantly the work we do in the cath lab. Still counts for maybe 25% of the mortality reduction that we've seen in the last half century or so. What's really made a difference of other treatments, EP procedures and the like, I'm not sure what else, heart failure management, that accounts for maybe another quarter. But look, half of the reduction in mortality or more is not attributed to these razzle-dazzle bits of business that we do in the acute care setting. They have to do with risk factor modification, getting the patients on the appropriate medications at the right time, keeping them there. And this is a lesson that, unfortunately, has been hard learned by cardiovascular practitioners across the board, in my opinion. The toughest nut to crack might have been the interventional cardiology crew. That's just a fact. So let's go on now to section 2, which is the brief financial report. This leads us to sad fact number 2. And what is the sad fact number 2? Sad fact number 2 is that my government would be pleased if I just stopped doing this altogether. Now, there's a bit of hyperbole in that statement, of course. The government wants to see to it that we provide appropriate care for everyone, particularly the Medicare beneficiaries. But let's be sanguine about this. This is really a critical issue now, and it all has to do with the money factor. Just very briefly, if you have any doubts about this, there are places you can go to test the veracity of the claims I'm about to make. This is a slide I also showed a couple of years ago. This is from a couple of years ago now. I didn't update it. This slide shows U.S. healthcare expenditures over roughly the period of my life. I was born about 5 years before this chart starts. We're about 5 years after the end of this chart now. But this roughly is what's happened in my lifetime. And what do we see? We see that U.S. healthcare expenditures went from about $27 billion annually to $2.7 trillion. A 100-fold increase in dollars, adjusted dollars, that have been spent for healthcare in this nation over a 50-year time span. Pretty remarkable fact. What else has happened? Well, everybody knows that the boomers are getting older, that the demographic, the employed demographic is changing in this country, and is changing in such a manner that people are very alarmed. The boomers are going to be retiring soon. And as those folks retire, they'll be dipping into that government pool of money to support their health care. And what's happening there? The projections are that between the 60s and 2030 or so, there will be about a 95% increase in the number of people dipping into that pool of money. At that same period of time, the projections are that the number of workers who are contributing to that pool of money and meant to sustain it will be falling meaningfully. This is obviously a big concern. So we got a money issue. All right, maybe we can figure out a way around that. We can save some money and get more people working, keep people employed longer. That's not the only bad bit in this. There's another bit in this. Here's a brief performance report. Sad fact number 3. I think I do a really great job. Unfortunately, I don't do nearly as good of a job as I think I do. And this is true not only for me, it's true for you. If you have any doubts, there are places you can go to learn about this. Here's an interesting graph that charts healthcare spending per capita by nation and plots it against life expectancy as a crude but useful measure of healthcare effectiveness, also plotted by nation. And what do you see? You see that indeed there is a bit of a relationship there, as denoted by the red dotted line, between the number of dollars that your government spends and how long you are likely to live. And that trend holds pretty well for the 15 or so nations that are represented on this graph, but there is an outlier, and that's us. We spend far more money than other nations, or many other nations, and we don't seem to reap the benefit from it. Now, why would that be? Well, again, I'm not a healthcare economist. I want to disclose my limitations, and I can only reflect what I learn about this. And I've read a lot about this. In this particular summary, I think does a nice job of encapsulating the big buckets of concern. The first is that we spend more money on healthcare in America because we can. We're a wealthy nation, a very wealthy nation. Now, remember a moment ago I showed you that graph that illustrated how much we've increased our spending over 50 years, a 100-fold increase in the number of dollars that we spend. But look at this graph. Same period of time, same source document. Over that period of time, our gross domestic, the percentage of our gross domestic product that is spent on healthcare hasn't gone up by a factor of 100. It's gone up by a factor of 3 or 4. Well, that's still a lot. But clearly, we are able to spend many, many more dollars without breaking our personal banks. And that is part of the reason why we spend so much money. You have to think carefully about how you would fix that. Another reason is variation in care. And you hear a lot about this now. We spend a lot of time about this. A lot of you have seen these heat maps that signify the variation in healthcare delivery, different sections of the country. You can get very granular on these maps. You can go to the Dartmouth site. It's free access. You can spend all the time you like learning about this. This particular map illustrates utilization of angioplasty techniques for Medicare recipients, broken down by county. And all you need to know is that the dark red areas are the places that use a lot of angioplasty. The yellowy areas are the places that use little angioplasty. This is per 1,000 Medicare recipients, so this doesn't reflect the population density. And what you see here is there is a roughly 10-fold difference in rates of angioplasty utilization between the lowest and the highest utilizing counties. Now you might say, well, okay, so here's our problem. We've got to get to those high utilizers and push them down. We got to get that under control. Clearly, people are getting along fine with the lower rates of utilization. Well, it's not that simple. There is an equal concern, or at least an additional concern, that we underutilize angioplasty in certain areas. And that's not good for patients either. Angioplasty, I believe, provides benefit to the patients who are able to access it. So there's that issue as well. You might say, well, where is the balancing point? I mean, how are we doing on average? This is pretty variable, but how are we doing on average? Well, I couldn't find anything specific to angioplasty, but there was this interesting paper from about 10 years ago, a little more, that tried to address the quality of healthcare delivery by assessing how often we do the right things for patients. The way they did this is they surveyed medical records and performed interviews with patients from about a dozen metropolitan centers around the country. They asked about something like 450 different healthcare variables, ranging from immunizations and prenatal care out to chronic care for chronic conditions like heart disease, lung disease, and so forth. And what they found was that overall, at least as of 10 years ago or so, we were providing good care, matching up to guideline standards and meeting patient expectations about half the time. About half the time. And it was equally poor between the acute care episodes and the chronic care episodes. We did really well with things like cataract. I'm not sure why cataract did so much good attention. We did very poorly with some of the really challenging areas like substance abuse. And that all rings very true to me. And chronic and acute care episodes of care that would call upon utilization of invasive cardiac services, about half the time it looked like we were doing the right thing. And this gap between what was indicated and what was actually delivered was, in the opinion of the authors, sufficiently serious to warrant real attention. And I do think we have heard that message, and in the last decade we have spent a lot of time trying to address this, because most healthcare leadership today agrees that these gaps represent a legitimate, significant threat to patient welfare and an opportunity for us to improve what we provide. And then the third big basket, or third large element that explains this gap between the number of dollars spent and the outcomes that we observe, has to do with what you and I get paid. It has to do with what you and I get paid. And although this is an uncomfortable topic, the fact is, in other parts of the world, providers are not compensated nearly as richly as they are in the U.S. Now, I'm not here to say that that's a bad thing. I'm pretty happy about that. And I'm not talking about us compared to Bangladesh or Tajikistan. I'm talking about healthcare delivered in Western Europe and the developed countries in Asia and South America and so forth. So I just pointed out as an area that will come under increased focus, will be of increased concern going forward for those that pay provide our paychecks. And by the way, the projections are not that rosy, although boomers are doing a lot better than the parents did. Estimates are that I have folks of my generation enjoy about 60% more disposable income than my parents' generation enjoyed. A big portion of that is being sucked up into healthcare expenditures, and the projections are that between roughly now and the middle of the next decade, our private expenditures on healthcare services are projected to blossom from about $200 million annually up to $1 trillion. So it's a really big expenditure. So what are we going to do about all this? I've tried to outline what the flashpoints are and the areas of concern that we have. I'm now going to shift and talk a bit about thoughts on how to get ahead of this and how to make a positive change. Now, there are a lot of different things you could propose, a lot of different ideas out there. I tend to like this idea of constraint. I think this is a very useful way to frame thinking. Section 4, embracing restraint, of course, comes along with its sad fact. And here's the sad fact about constraint. You don't have to do it. But if you don't, you're doomed. Anybody know who Edward STEMI is? I know Dr. Weintraub does. You do. He was an engineer by training, but and actually is widely regarded as a brilliant mathematician. But he's best known for the social impact he had following World War II. He was a keen observer and had a very structured mind, like most mathematicians, and was able to go to post-war Japan and help them develop models of reconstruction that were based on collection of actual information, performance data, that was then applied to their rebuilding of industry, and is largely credited with Japan going from literally ashes to now the second most vibrant economy in the world. I think it's still second, at least it was for a long time. I'm not sure how China may have changed that today. But Edward STEMI also had a number of poignant kind of Yogi Berra kind of sayings that have become legendary in MBA programs and that sort of thing. And this is one of his more famous sayings. It's not necessary to change because survival is not mandatory. And that, ladies and gentlemen, is a true summary of our condition in 2016 in healthcare. I think that we have some great opportunities, though. There is low-hanging fruit there. In my opinion, this notion of constraint works really well. You can constrain access, you can constrain payment, you can constrain variation. All those things should be helpful. Let's talk first about constraining access. Well, as far as the CAPVAC is concerned, one thing we can do is just simply restrict access. That's it. Just make it really, really, really hard to do. Of course, this starts to sound a little bit like death panels, that we're just Christiana Care is not going to offer you invasive services for your heart attack. It's probably not going to fly. So we can strike that one off. But what we can do, and indeed what we are doing today, is constrain access to only those invasive services which are known to provide benefit. This isn't really novel. This isn't really new. We do this already. Everyone here knows about insurance pre-approval processes. I just read this morning that the Delaware American College of Cardiology chapter has decided to take up a new initiative to simplify this pre-approval process. It's no secret to practitioners that when you have to call an insurance company to get approval for a procedure, it can take the better part of your day. It's a grueling and difficult process, and many believe that insurance companies use this as a means of discouraging delivery of appropriate care, and there have, as you probably know, been lawsuits fought successfully against insurance companies who have in fact played that game in the past. So we have already a model of operation under which we exist today. We know about our government's position on this. Medicare announces both at the national and local level what are called coverage decisions, which are basically statements from Medicare telling providers what they will and will not pay for. It's an imperfect process, but there is a process in place. And then most of you know about the RAC auditors, the recovery audit contractors. These are private companies that are retained by Medicare to review medical files and records to look for evidence of inappropriate billing practices. And the way this works is the RAC auditors are allowed access to your files. If they find you have billed inappropriately, you will be asked to pay Medicare back. And if you have billed too often, too much inappropriately, you will not only have to pay the money back, you have to pay back multiples of that dollar amount in the way of a penalty. And then the RAC auditors get a percentage of that cut, of that savings goes to them. And of course, if you're really found to be a bad actor, then the Department of Justice gets in and you're investigated for fraud. And this is not theoretical stuff, guys. This happens in every hospital around the nation every day. And this is really going on. I will confess that for a long time, I felt, particularly when I was at Mayo, which is kind of a cloistered place, and kind of you tend to feel, like everybody around you is really a high performer and, great ethical standards and so forth. And I really believe that, these Mark Madej characters down in Baltimore that, go to jail because they were doing a lot of inappropriate stenting, I really thought they were rare as hen's teeth. They're not rare as incident. And it's not just the cath lab. Every corner of our healthcare system has these poor performers who either inadvertently are doing the wrong thing or not so inadvertently defrauding the healthcare system. All of us are accountable for it and have to help remedy the problem. Now that's the pessimistic statement, but the optimistic statement is that I do believe that the majority of operators and providers are ethical people of high standard, and that they support and contribute initiatives to enhance the care that we provide and do the right thing. That's possibly best crystallized in this idea of appropriate use criteria. Everybody's heard of appropriate use criteria. This is also not new. It's sort of got new attention in the cath lab because it's a relatively new thing for us to be doing. But appropriate use criteria have been around for practices for a long time, and so the idea is not so new. It's also an imperfect process, but it's a reasonable one that asks clinicians who are involved in a given discipline, say coronary angioplasty, sit alongside people who are clinicians but who have no dog in the fight. They're not interventionalists. They're just good people, good doctors trying to decide how to do the right thing. And then alongside them are others who are even more disinterested parties. And they go through this formal process of trying to imagine all the different scenarios, all the different reasons a patient might come into the cath lab and say, all right, in that setting, that's perfectly appropriate. In that setting, no, not so much. And in that setting, that's malpractice. And they provide then a summary of those decisions in the form of a simple graphic that you can use to help guide decision-making on the fly. Now, I can tell you most interventional cardiologists, when this really kind of broke out in about 2011, 2012, the people, they really rebelled. They just hated the idea of this. They hated it because it just felt so constraining. But I contend that the ethical, high-performing interventionists really concerned and interested in doing the right thing welcome this, or they should have welcomed it. And I think our guys here at Christiana Care will welcome this, as we're currently rolling out a process to make this available as a tool for on-the-fly, real-time decision-making in a cath lab. And why would you not welcome this? You look at this chart, and even if you're down in the red zone, that's inappropriate, or what we now call rarely appropriate intervention. There's nobody's going to step up and say, you can't do it. No, you can't do that. It's inappropriate. No one is going to say that. Why? Because we recognize that there are times when these very well-meaning, smart people drafted out a scenario, a theoretic model that matches as close as possible the patient that's actually in your lab, and they decided most of the time that just is not right. But we also know that part of your privilege and responsibility of being a clinician is that you're entitled to exercise judgment. And if you feel that your patient, despite which box they fall into, is best cared for with an interventional procedure, they will get that interventional procedure. We, as leadership of the service line, will ask that you explain that you defend your decision-making in writing so that we can go back and argue it if it comes up. But no one is going to throttle you or tie your hands and tell you you cannot practice because you don't fall into the right box. Hopefully, it's going to be a rare event. This naturally then opens a discussion about whether tools like this can be used to help determine payment. Remember, the money is at the root of all of this, is this. And so should we be using AUC in a cath lab and in other parts of the practice to help determine reimbursement? Well, I'm in that camp that says this is a bad idea. Even though it's not, immediately obvious why it's a bad idea, I believe it's a bad idea. And my principal reason for feeling that is, as I just explained, there are going to be times when patients who are deemed appropriate really should not get stents, and vice versa. Patients who are deemed inappropriate should. It's a little bit of a blunt tool to say we're going to use this schematic to inform the insurers and the other folks that pay for services as a broad heading. Now, I would allow that if you took that as a first step and had a very robust means of appeal, that might win the day, that might work one. But let's remember that this idea of appropriate use criteria is meant to guide clinical practice. It's not meant to be used as a tool for determining physician or healthcare provider reimbursement. And so there's currently a battle going on in New York State, where I was previously. The state raced to this, and they quickly announced, reasonably quickly, announced that New York State Medicare would refuse to pay for any patient who received a coronary interventional procedure in the setting of an acute coronary syndrome that was deemed inappropriate. Period. That was that. Full hospitalization refused. Several organizations pushed back. Many of you know that I'm involved with the Society for Cardiac Angiography and Intervention. And they pushed back hard and got New York to overturn its original decision. But I understand that under further review, they have gone back to their original position. So to my knowledge, this is still the case in New York State. And New York will not be the last. It is of concern because we still have to wrestle with the fact that patients don't come looking, one like another. There's tremendous variability. Just one quick example. Here's a fellow, 70-year-old smoker, gets on a stress test. In the recovery of the stress test, he has an EKG that looks like that. And most of you that read these things will be a little alarmed because this fellow has ECG changes that are right at the edge of being diagnostic. But if they are diagnostic of ischemia, they denote possible widespread ischemia. And on the basis of that, this fellow went to cath. I don't know how well you can see that, but all the arrows are showing you the important news here that this fellow had blockages all over the place. What do we do? Well, I guess I could put in 8 or 9 stents and fix the guy. I could send him to bypass surgery. That's equally or more expensive for many patients. Is that the right thing to do? I don't know. Is it the right thing to do? Not sure. Not sure. Because although this fellow had diffuse ECG changes, I don't know just by looking at the angiogram which of those narrowings I have to treat. Remember, 90% of patients in this country who have a diagnosis of coronary artery disease never require intervention or bypass surgery. They have coronary blockages like that. They're managed very effectively with lifestyle modification and good medical care. And by the way, those are the things that I showed you earlier that will help us best assure that they're here for next Christmas. Not stents, not bypass surgery. And we have wrestled with this, and we do have some tools in the cath lab. I'm not here to talk about that stuff, but just as a point of interest, we have taken this stuff to heart, and in the cath lab, we use now tools to help us look at all those different blockages and help ferret out which ones really will benefit from a stent, and which ones we think soldier on with medical therapy. This is one such tool. It's called the Fractional Flow Reserve tool, and it looks to test the physiologic impact of all those different narrowings. And the red line and green lines denote a pressure difference above and below the blockage, and if it reaches a certain level, then you treat those patients because we've got good evidence that treating them improves their outcome. But no matter how nasty the narrowing looks on the angiogram, if the impact physiologically of that narrowing is not great, we defer therapy. We may see them some other day. We may have another opportunity to put a stent in that lesion someday. But we don't do it at this moment. Because again, we've taken this to task, we've carried the water on it, we've done the studies. And I believe ethical, sound reasoning interventional cardiologists will look at this and say, yeah, I know the narrowing looks bad. It's not physiologically causing ischemia in this man right now. He will not extract benefit from a stent. I can only harm the guy by trying to put one in. I'm going to make sure that I do everything possible to improve his lifestyle choices and his medical therapy. Okay, so now we get to constraining variation, which is perhaps the most interesting thing. This is a place where a lot of folks spend time thinking very critically and carefully about where we can actually affect change. There is no doubt that this is a fabulous opportunity space. This is a great paper that came out just last month in JAMA. creates a nice broad outline, and it doesn't say anything that earth-shaking to me, but it's a nice confirmation that the sorts of things that we're doing today are on the right path. What they recommend is a framework, is to establish a work group that has all the stakeholders at the table, have those people help in the decision-making process to define which things in your particular practice, in your particular community, make the best sense for attaining the objectives you seek. You make sure that those conform to proper practice guidelines and standards, and then you look for your best opportunities to make the changes. Today, that largely involves looking at electronic tools that can be helpmeets to standard clinical practice. Some of us just met yesterday with a company that's trying to develop electronic tools that patients can carry home with them to improve their compliance with their medical therapies and the reporting of changes in their healthcare status to their providers. And I hope that all of you, or most of you, saw a memo that went out in email yesterday or the day before about the commitment Christiana Care has made in this space. Our IT guys are working like slaves. I don't know if we have any in the room. I suspect we may. They work very hard. There's a lot of demands. That notwithstanding, the IT leadership has said, we recognize that personalizing care is a priority topic and has to be on our checklist for the next few years ahead. To that end, we will make a commitment to provide resource to build meaningful applications, apps, other electronic solutions to enhance healthcare delivery. You just convince us what needs to get done, and we will help you get there, which is a pretty amazing commitment. As an example of how this is being handled at a more grassroots level, this is I don't want you to read this. This is just a process map of our patient care algorithm for those that arrive at Christiana Hospital with the, not the big one in heart attack, but the somewhat less severe heart attack. We recognized that there was significant variability in the way we were managing these patients. And so as a part of a clinical pathway development process, we analyzed what we were doing. The yellow flash points that are highlighted now with green circles represent those places in the pathway that we not only recognized an opportunity for improvement, but the opportunity for improvement was largely driven by constraining variation in care. And there's an additional one here at the end, now in the red circle, that involves the aftercare of the patient, a handoff to outpatient providers, that also could be improved chiefly by constraining variation and how that process was managed. And I just want to make that point that the Christiana Care leadership from the hospital system down into the service lines is paying attention to these issues and crafting out solutions that embed the principles I'm talking about. Our pathway is new, as are all the new pathways, all the pathways here, as you know. It's a little early to know exactly how far these things will take us, but I am happy to report that at least our preliminary information is that we are seeing improvements in the metrics of pathway performance and are optimistic that they will win the day. Constraining payment. Well, how are we going to do this? Well, I'm not a healthcare economist. This is not my wheelhouse, and I'm not here to try to educate you around this. I will just make 30 seconds worth of comments about MACRA. Everybody's heard of MACRA by now? MACRA is the next new thing. It's the next wave of government payment for the Medicare population. And MACRA is an acronym for the Medicare Access and Chip Reauthorization Act. It's a big law. It's a big law. It dumps a bunch of other laws and replaces them. It replaces the Sustainable Growth Act, the Growth Rate Act. Some of you know about this law that goes back into the 90s and is meant to constrain the rate at which Medicare payment is increased year by year. And every year doctors would advocate on the Hill and say, wait a minute, we can't get along with that. We've got this new widget and we need more. And every year the Senate would capitulate on it and say, okay, the doctor affects every year. That goes away. Importantly, MACRA accelerates the shift away from payment for volume to payment for value or value-based performance. It extends the Children's Hospital Insurance Program. Those are all just kind of the top-level things. Some somewhat less well-appreciated facts about MACRA, which are worth knowing about. MACRA cuts payments. MACRA cuts payments to hospitals, and MACRA cuts payments to providers after acute care episodes. MACRA also cut some of the CMS benefits to its beneficiaries. So there was a thing called the Medigap coverage plan, which allowed Medicare beneficiaries a way of avoiding payment for their deductible. That goes away. And very interestingly, MACRA requires that high-income beneficiaries pay a higher percentage of their costs, their deductible costs, or their total costs, which has gotten almost zero play in the media. But I think this is something for us to pay attention to. To my knowledge, this is the first time that the government has applied a means test, effectively what this is, to Medicare benefits.
Actually, they're doing that now.
They're doing that now?
Yes, they are.
Ah, well, there you go. Thanks, Andrew. And the last thing to be said about MACRA is that if you think this is the new wave tomorrow, you're too late, because we're already in the fix. I'm not going to, this is a very busy slide, you're not meant to pay attention to it. I just wanted to highlight that the final law was issued in April, but MACRA has been basically gaining momentum, gaining velocity here since last year. And is this really going to win the day? Is this expected to actually save money? Well, the projections are that the over $200 billion annual payment to CMS beneficiaries, about a third of those dollars may be saved if MACRA fully achieves its end. We'll see, but that's what is projected. Okay, final section. What is the invasive cardiovascular value proposition? Well, I have good news for you. This one does not have a sad fact. This one has a fun fact. The fun fact is that we know what to do. It's not really that hard. And I think the invasive cardiovascular value proposition can be displayed simply in this four-box model. These are things that we already know to do. We've done them to some degree already, but we just need to do them better, and we need to do them more effectively. Just quickly to go around this, starting in the upper left-hand corner. Core measures. Core measures have been around with us for a couple of decades now. We know what that is. That's just an independent yardstick confirming that you as a doctor are doing the things you need to do to help your patient get better and stay well. We have, in our service line, multiple standing committees that in some manner or another touch this notion of core measures, and I'm including under core measures the idea of performance metrics that impact reimbursement as well as patient outcome measures. Make no doubt this is a focus of service line leadership, not just in mine, but I'm quite sure all the others. And we, in our service line, benchmark how we do in this regard against like institutions and other agencies. Appropriate utilization, I touched on this a moment ago. We are, as I said, exploring novel ways that we can leverage appropriate use criteria for our practice in the hope that we can improve the performance, our performance collectively, by informing practitioners in real time of the nature and consequence of their decision. We're tying that in with our clinical pathways. We get quarterly reports from independent data registries that let us know that we're actually doing well or not doing well. HCAPS, you all know about hospital consumer assessment of healthcare professional services, and this is basically just the patient experience piece. As you know, all of our patients, inpatients, receive surveys at home and are asked to complete them and let us know how we did. We really think this is very, very important in our service line. We have recently made the decision to send out members of our leadership team on a periodic basis to just randomly talk to patients about their experience. How are you doing? Now, part of it is it's a way that we can learn about how well the nurses are really tending to the patients. How often are folks really washing their hands when they come to change a dressing? How much are they bothered by the noise at night? You know, that sort of thing. But beneath all that, what we're trying to do is assay how do patients perceive us? How do they feel we're doing at the highest level? Do they like us? Do they think we're doing a good job or not? Hospital readmissions, this is a very deep topic. We can talk a lot about just this piece. We are paying careful attention to that. We believe our clinical pathways, the pathway we launched this year and those ahead, will help us reduce hospital readmission. Hospital readmission is undoubtedly going to bubble up as a key metric for future pathways. We are participating in bundled service projects with CMS for heart bypass and the like. As a part of that, we measure how well our activities impact readmissions. The readmissions are very expensive. The hard part, of course, is that, at least for the angioplasty group, we know that a lot of the readmissions have little or nothing to do with the angioplasty event. Good, sound data, if that's the case. But that doesn't get you off the hook. And in my opinion, it should get us off the hook. It shouldn't. It shouldn't. Even if we know that patients come back because they tend to fall down a lot after angioplasty and come back with broken arms. Well, listen, if I know this to be true, I should, in some manner, own it. At a minimum, I should partner with the guy to make sure people don't fall down home. You know, it's that sort of thinking that we have to carry forward, not just to win the financial game we're playing, but to really get to a better place in patient care. All right, so that's it. I've spent my hour. I'm going to conclude just by saying the following things. First, I think we all recognize we live in an environment of great change. Certainly, this hospital system has experienced great change in the last couple of years in the context now of a global environment that involves great financial, epidemiologic, and public opinion change. And the interventional cath lab could be the poster child for where the shoe pinches in regard to all these changes. Payment is now and will forever be linked to a different set of metrics than they have been in the past. And it doesn't get your attention, it should. I've tried to outline why that's the case, the financial imperatives that the government faces, and in some manner are, I suppose, faced by the private payers as well. I'm going to assure that we have to walk this path, even when we know that there are imperfections in the processes of measurement and correction. I nonetheless am convinced and will remain convinced, I think, I don't think I'll change my mind, of the value of the invasive services that we render. I believe that we enhance life substantially and under a limited number, but few really important clinical circumstances, we save lives. So we have to nurture that. We have to grow it, but we have to make sure that we constrain it and do only the things that need to get done. If we can't articulate the value of what we do today better than we have in the past, then others will do it for us. And as I explained, exercises like the AUC and the RAND process can be useful, but no one will be better informed about the value of services rendered than the people who render them. So we have to agree to participate in the process. The good news in my mind is that the necessary steps to take are, in my opinion, apparent. If you have the right leadership, then things should go well, as long as we stay focused on the right metrics. And then I close just with this photo of Andreas Grunzig, the father of angioplasty, who, has been a little bit of a, cult of personality around him, I suppose. It's a little overdone. But one of the things I do admire about the legacy of Andreas Grunzig was not just his legacy of innovation, but Grunzig was incredibly self-critical, and he was critical of the science. And this photo was taken from one of his many courses that he ran in Zurich. I never had the pleasure of attending, but all those that went will tell you the same thing, that it was a mix of incredible excitement and enthusiasm about this amazing tool, and great caution, and a great sense of being circumspect to assure that you don't do something stupid, because we really can hurt people. And I think if we approach things that way, we'll be okay. I've run out my hour. I appreciate your coming today, and I'll answer any questions that you have. Thanks.
In terms of the AUC reporting, is there a report card, if you will, so we can see where we stand as per?
I have yours in my office.
I mean, because unless you know.
Yes. So the National Cardiovascular Data Registry, the NCDR, runs a registry called the PCI registry. It collects a lot of information about the interventional practice. We are participants. In the past, PCI has produced quarterly reports that were global reports on the performance of your hospital. Increasingly now, it's become more granular, and currently, cath PCI reports are available on a per practitioner basis. So I could get a report that will tell me specifically what the AUC findings were for a specific provider. That's available. We try to get ahead of that, and as I've explained, we want to make sure that we minimize the opportunity for mistakes in that regard.
Dr. Garratt, sometimes the cardiologists are required to do tests ordered by primary care doctors, or invasive cardiologists are required to do invasive requested by non-invasive cardiologists. Who decides the inappropriate? If you decide that the test is inappropriate, you refuse?
Well, it's a multifaceted question I think you're asking. On the one hand, part of what you're asking is, who decides if this whole episode of care is appropriate? We got this fellow in here, he's got some chest pain or something, and somebody decides a stress test is appropriate. Well, who knows if that's appropriate? And then based on the findings, you can go to the cath lab. Is that appropriate? And in a cath lab, he gets a stent. Is that appropriate? So the reality is that the appropriate use criteria are intentionally parsed out in each of those cubbies so that you can help. A provider is helped in making a decision about the appropriateness of action at that decision, not the one that comes afterwards. For that, you go to the next step. And that's a reasonable working model. But I like the nature of your question. The other facet I think I was hearing you ask is about, maybe I misunderstood, about the supervision of this, the how this is managed, how are appropriate use criteria managed within each of those cubbies, and that's variable. It can be variable across our service line. It will be variable outside of our service line. As I mentioned, we are now test driving this idea in cath lab of crafting out a process that will force operators to know what the AUC is before they begin angioplasty. And we can do that. I did that successfully at the last hospital I was at. It really made a difference. It moved the needle on our appropriate use findings. And it's not onerous. It's not burdensome. It's helpful. It's helpful. Now, if that works well, maybe we can replicate that in the echo lab, in the nuclear lab, and so forth. All right, we're after hour, guys. Thanks a lot for coming.